We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we have got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we are now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology.
So what is basically osteoporosis in pediatrics? Is it based on DEXA? No. The DEXA Z score of less than -2 doesn't say that the child is osteoporotic, okay? The basic diagnosis depends on clinical presentation. If the child has any single vertebral fracture or has 2 long bone fractures in less than 10 years and more than 3 or more long bone fractures in a child who is less than 18 years with a BMD-Z score of -2 standard deviations is considered to be osteoporosis as per the International Society of Clinical Densitometry official statement in 2013. So what do we do when we diagnose a child to have osteoporosis, or how we go and approach how we approach a child who has a bone fracture? Okay, so this is an approach. This has been recently published in 2024. It's a bit complicated approach. We'll go step by step and understand how to approach a child who comes with fracture. So first step, whenever a child comes with fracture, one needs to identify whether this is fracture because of some basic metabolic causes like rickets. So any child who comes with fracture, one should do calcium profile, vitamin D, rule out rickets or vitamin D dependent rickets. Then also one has to look for non-accidental injury. Okay, in that cases, one needs to rule this out first before labeling the child osteoporotic. The second step will involve evaluating the skeletal phenotype of the child. One knows that the child may be at risk of primary osteoporosis, like in cases of osteogenesis imperfecta, which is the most common cause of osteoporosis in children, and secondary causes, which can be because of acute and chronic conditions like a long-term steroid use or a patient who is having cerebral palsy. They are at risk of secondary osteoporosis. So, how do we evaluate the child for skeletal phenotype? So, one can look at the clinical features. We all know that osteogenesis imperfecta will present with blue sclera, early onset fractures, recurrent fractures. But there are some other conditions also which can present with primary osteoporosis in pediatrics, which includes some skeletal dysplasias. One can look at skin laxity for some conditions like Ehlers-Danlos, which can have primary osteoporosis, vascular calcifications, spinomuscular atrophy, or some syndromes where the kids can have primary osteoporosis. If these features are present in a child with significant fracture, one may consider this as primary osteoporosis. Secondary causes, as I discussed previously, are some critical organ dysfunctions, inflammatory conditions where we use long-term steroids, some endocrinopathies which have been long-standing, and some medications like glucocorticoids or some lifestyle conditions which add to all these conditions resulting in secondary osteoporosis. So if you find any clinical features of this in a child with a significant fracture, then the child needs evaluation for osteoporosis. So the step 3 will be labeling the fractures, whether the fractures are major fractures or they are minor fractures. So major fractures are the fractures of the long bones and vertebrae. Also, flat bone fractures are considered to be major fractures. In these cases, even in absence of, or in these cases, less supporting evidence is required to confirm the diagnosis of osteoporosis. But when you have fractures of tibia, fibula, radius, or ulna, you need major supporting factors because these bones are very commonly fractured in pediatrics. Okay, so in that cases, you need stronger evidence to say that the child is having osteoporosis. So once you confirm that the child is either having features of primary or secondary osteoporosis with significant fracture, either fracture of the vertebrae or the long bone, you can go ahead and manage these kids. In case when you don't find any features, you can use the criteria of ISDC's 2013 statement, which says 2 fractures before less than 10 years and 3 fractures before 18 years of age. In that cases, you can also manage the child as osteoporosis. So how do you evaluate which kids will require treatment? So see, one needs to understand whether the child is likely to recover on its own or not. So in conditions where you know that the child is having spinomuscular problems or he is a case of osteogenesis imperfecta, the chances that the child's bone density will improve on its own is less likely. And in these cases, you might treat the child. But in conditions where the child is treated for transient conditions like leukemia or he has temporary immobilization, in that cases, you can wait and watch, monitor the child over 1 year and see how the child is having further risk of fractures or not. If the child is recovering on his own, you don't need to treat these conditions, just monitor. Okay, so let's talk about the treatment. Since we know normal bone remodeling and abnormal remodeling, so anything that affects the bone remodeling will cause bone loss. So the treatment options are basically targeted towards this. So the treatment targets for low bone mass will be targeted towards decreasing the osteoclast, increasing the number of osteoblasts or osteocytes. So the treatment options that are available in pediatrics or the treatments that are available are anti-resorptive, which includes bisphosphonates, denosumab, SERMs, and calcitonin, which are anti-resorptive. Bone forming are recombinant PTH. And the dual-acting newer drug is romosumab or sclerostin inhibitor, which is still in pipe. Hello. Yeah. So the guidelines, what does the guidelines recommend that in pediatrics, only calcium and vitamin D treatment has been recommended officially by the 2020 guideline which was published in the Rheumatology Journal. But because of our long-term use of bisphosphonates in pediatrics, it has been seen that bisphosphonates are helpful in improving pediatric osteoporosis, mostly in conditions like primary osteogenesis imperfecta. And we have a huge experience of using bisphosphonates in these conditions. So what are bisphosphonates? Basically, bisphosphonates are anti-resorptive agents. They act on the osteocyte and cause apoptosis of osteocyte. Also, they modulate the signals to the osteoblast and osteocyte, resulting in new bone formation. That's how they improve the bone mineral density or the bone mass. So the bisphosphonates that are available are either oral versus IV. So oral bisphosphonates that are available are alendronate, or IV that are used are pamidronate or zoledronate. So which are better in pediatrics? Anyone? There was a recent study that has been published in 2023, which is a meta-analysis which studied the efficacy and safety of bisphosphonates on childhood osteoporosis. So what they showed that both the IV as well as oral bisphosphonates are well tolerated, and also they have equal efficacy. But yes, there are some studies we say that the oral bisphosphonates does not have any role on the cortical width or increasing the cortical thickness. So hence, because of the huge data that we have, we prefer IV bisphosphonates in pediatrics. So the two common bisphosphonates that are used are either pamidronate or zoledronate. But with availability of zoledronate, more and more people are switching towards zoledronate. So these are the basic doses that are used. These are the initiation doses. And the side effects we know are flu-like reactions at the beginning of the dose, hypocalcemia if the child is not well treated or prepared before giving bisphosphonates, and the very rare side effect that has been seen is osteonecrosis of jaw, which has been less seen in pediatrics. The only contraindication for bisphosphonates is acute renal failure. So how long should we treat a child with bisphosphonates? So if you see the child, you have to monitor the child and ensure the child has stabilization of osteoporosis. That means there are no new vertebral fractures, vertebral bone reshaping has been achieved. There is no back pain. There are no new long bone fractures, and the BMD-Z scores are improving or normalized. In these conditions, and if the child has primary osteoporosis, you may switch the child on maintenance doses. So what a maintenance doses basically mean is you decrease the dose by 50%, what you are giving at the start, or even lesser than that, just to maintain the bone mass. And in primary osteoporosis patients, like in OI, some guidelines do say 2 years, 5 years, but this latest guideline says until the epiphyseal fusion, we can give bisphosphonates in patients with primary osteoporosis. And in secondary osteoporosis, we can give as long as the risk factors persist. If there is no improvement, one can continue the initiation dose till the stabilization is achieved. And once it is achieved, you can switch to maintenance dose. So the another drug that we discussed was denosumab. Denosumab is a rank ligand inhibitor, which again decreases the osteoclast activity and decreases bone resorption. It is available for subcutaneous injection, which can be given every 6 monthly. The major side effect that has been seen is hypercalcemia and rebound bone resorption. So what about the safety of denosumab? So this was a recent study that was published in 2024, where denosumab was tried in osteogenesis imperfecta patients. So here they did had 84 patients, and they were equally divided in denosumab group and zoledronate group. What was observed here, if you can see, that the denosumab group had major discontinuations. The dropout rate was around 7 at the end of the study of over 1 year. And the main reason was hypercalcemic crisis. So what does this study, in this graph, you can see that the hypercalcemia was very significant with denosumab compared to zoledronate. So the study concluded that hypercalcemia is very severe and common side effect in pediatrics, and hence it cannot be used as a first line drug. Bisphosphonates still hold true, and they are more first line drugs for pediatric osteoporosis. In addition, there are some anabolic agents which are in trial, and they are not used in pediatrics. Parathyroid is not used in pediatrics, though it is used in adults because of the risk of osteocarcinoma in children. And that's all, I think. So my take-home message will be osteoporosis is more a clinical diagnosis. Adequate calcium and vitamin D supplementation is essential. Bisphosphonates are the mainstay of treatment in pediatric osteoporosis. You can refer to these guidelines for further evaluation.
I think thanks a lot, Dr. Sajli, for the wonderful talk. I think the one important message about bisphosphonates versus denosumab debate is that denosumab basically do not have a long-term impact as far as osteoclast is concerned. And when you're using denosumab, as soon as you stop it, the osteoclast which was suppressed suddenly go into a overdrive, and that causes hypercalcemia. So when you're using denosumab, there is no end date. If you stop denosumab, you will have rebound hypercalcemia. So some people in adults say you use denosumab and then switch to bisphosphonate. So in OI, you have to treat for a long time, and maybe sometimes you have to stop. This is not going to be a very good option on that perspective.